Plateau is the last person, the last presentation we have. Esther, can you join us here?
Sorry, my slide is not presentation-able. I didn't know it was going to be a presentation.
It is, the content is.
So I guess we just talk. Okay. So primary health care, I'm here to talk about the problems and possible solutions of primary health care in Plateau. Now, primary health care is supposed to be your first go place, yes, in every community. But we both know. I know. So now I just want to briefly state the problems why you don't consider coming to primary health centers first and possible solutions. Okay, so our major problem is insufficient personnel. We don't have people working for us. The thing is that for the past, I'm sorry. Okay, now the problem is for the past 5 years in Plateau, primary health workers have been paid 50% of their salaries. So that's every single month you are being paid 50%. Now this has made a lot of workers to go to other places to look for jobs and all. And then initially there were stipends they give to volunteers, and then IT students, nursing and interns. But now they don't give them. So most of them rather go to JUTs, go to other teaching hospitals and tertiary centers. So we are left with very few people in primary health centers to give, and then the few people are usually overworked and so. And then Plateau has had its own share of insurgency and we are still yet to recover from it. So there are places that during the crisis, the riots were closed, that are yet to be opened. Some were burnt and are yet to be rebuilt. So we have that problem as well. And then we have some NGOs that help, like APIN and some. But then there's over-dependency on them. Now, this APIN is supposed to be AIDS prevention, but then they are the ones digging boreholes for us, building for us, and giving us vaccines. So it has gotten to the point that we are actually getting over-dependent on them. Okay. And then poor satisfaction. Obviously, when you are not paid well, that's what you get. Then insufficient funds. Okay, primary health care are meant to give free or very minimal services, but we have to, the fundings usually come from the federal government or the little earnings we get. So we had to compromise to actually charging for prenatal care for some of the basic services that are meant to be free, yet it's still not enough. So we have cases of, okay, there's actually a lady, Palang, she went to the Guaradog Primary Health Center there and she needed to scan, she had an infection, PID. So she needed to scan and it was 1,000 naira. She said she couldn't afford 1,000 naira. So she went to meet her neighbor who had a pharmacy, would I say a chemist. And she ended up drawing her blood, giving her injections and giving her a lot of drugs. As at the time she came, she was 34 weeks pregnant. So as at the time she came to our center, the placenta was already infected. We couldn't even save the baby because of 1,000 naira. If she had actually gone for the scan, we would have known what's the problem and it wouldn't have extended to that point. And you couldn't blame her completely, entirely, because actually the scan was supposed to be free, but then we can't. So that's one of our major problems. And also, amidst the lot of problems, there are also solutions I think can. And then yes, one of the problems I forgot to is wrong perception that the community have about primary health workers. Once you say primary health workers, they think we are underqualified. They feel the services there are poor. And so you see people going all the way to tertiary institutes where they line up for malaria treatment, something you can get close to you. But then you feel the primary health care as they are quacks and all. That's one problem we have. So solution, briefly. Community mobilization and advocacy. We could organize rallies to inform these people that the people in tertiary institutes, the people that work in private hospitals, are the same people, at least the same qualification in primary health centers. So if they could come and risk and prevent all the time waste and all, we actually keep the same quality of. Then capacity building. need to be trained. Yes. Workshops, seminars, and courses. We ourselves to constantly need to be trained, so you don't feel we are so much quacks. And then provision of funds, that's the problem, funds. And also involvement of non-governmental organizations. I was excited when she said we should list the project. I don't know if I can give more than one, because we have a lot of, we are, it's critical. So please, your NGOs, your organizations, you could invest in, instead of going to the tertiary centers, they don't usually get to us, so you could come straight to us. We need your help more than most of these centers. Then intersectional collaboration, it's not necessarily, it shouldn't be restricted to health centers. Like we know Plateau for potatoes, veggies, and we could also have things like, at least it could help in sourcing funds for us.
Nutrition.
Yeah, so we could divert, yes, we could divert into other sectors, not necessarily health. Okay, so conclusion, I think, to my understanding, the conclusion is actually 3 A's: awareness, attitude, and action. Create awareness, change our perception. Even the government, you just feel you can come and tell us we'll do this, we'll do that. We can through diplomatic advocacy talk to them that you need to deliver what you've promised, and no. And then action, not just sitting and saying we can, me, you don't have to be that big. You can come and volunteer, you can come and help, and not make a
Thank you very much, Esther. So our presentations are finally done. Ijoma.